I'm interested, Vernease, in your organization, CASH.
Yes.
How did that get started, and what is it that you try to accomplish through that vehicle?
Well, we got started because of the very statistics you just shared with us. And I say that CASH is an excellent example of democracy at work. The people saw the differences between their health outcomes and the health outcomes of the majority population group. And
so you're talking about racial and economic disparities.
Racial, economic, at-risk groups. Mm-hmm. And our health outcomes are so different for the same disease. We're talking about trying to achieve 100% access, which is one of our Healthy People 2010 goals. Mm-hmm. It was a national goals that were set. And we haven't been able to even begin to approach reaching those ideal standards that we would like to reach. So the people came together and began to talk with the health department, began to talk with the state and national offices of minority health, began to talk with institutions of higher ed like Pfeiffer, Johnson C. Smith, mm-hmm. UNCC, and Queens. And as a result of that, we held a key leadership symposium, which led to community health symposium. And now we're about to have next Thursday our 4th annual community health symposium at the convention center. For the first year, we concentrated on heart disease. Mm-hmm. Second year, it was cancer. Last year, it was diabetes. This year, it's HIV/AIDS. And next year, we hope to look at either infant mortality or mental health. And so this is an excellent opportunity for people to come out and get health education materials and resources that they can take back and share with their families, their church, mm-hmm. Their neighborhood associations. And our goal is to connect people to services and services to people.
I want you to take this a step further.
Sure.
And either one of you can answer this question. Sometimes when I'm talking to people about disparities, mm-hmm. people tend to think about access issues, mm-hmm. as to whether or not a person has access to the system, when in fact, disparities is a much deeper issue. Help me put a face on it for the listener. If you're talking about heart disease or you're talking about diabetes, how does the disparity play into the treatment, the diagnosis and the treatment and the outcome?
Let me give you a real example.
Okay.
We did screenings, prostate screenings last year. And one gentleman in particular comes to mind. He got his screening at church because we're trying to take these screenings to where people live, mm-hmm. work, worship, and play. Okay? So we took the screenings to the churches. And one gentleman was screened after church, and he had very negative readings as mm-hmm. a result of the screenings. But here's the key. He had been to his physician for his annual physical the week before.
And it didn't show up.
Had been going every year. And this gentleman was 60 years old. And it didn't, no one screened him at his physician's office. So then our health providers were able to go back and say, we will contact your physician mm-hmm. again, sent him back, and he was treated, and I think his life saved.
As a result of that.
That is what we are talking about. It's not necessarily that people aren't going to the doctor, aren't trying to access programs, but for some reason, the minority and at-risk population groups are not being...
with the same level?
Exactly, of treatment.
What if you have a patient who has heart disease or diabetes, and we look at the issue of disparities? How can that treatment be different?
Well, for one thing, it's often much delayed before the person is diagnosed.
Because the person doesn't have the means to access the system.
Secondly, the system we have worked out often will pay for high-priced procedures, but not for ongoing prevention and early mm-hmm. interventions. Mm-hmm. The New York Times has held a series over the past year, a remarkable series on diabetes treatment. The most striking example of that, documented in one of those multiple-page New York Times articles, was, I think it was Mount Sinai, had a cost-effective preventive treatment to manage diabetes. However, the insurance companies, and these are commercial insurance companies, not necessarily involving either racial, ethnic, or economic disparities, they would not pay for that care. And the administrator of the hospital basically had to close that down because it didn't pay the cost, even though it certainly saved patients going through, for example, amputations of feet and other limbs. But the insurance companies would pay $10,000 for an amputation. So one of the things that I think cash, one of the great contributions that cash makes is that it really works very nicely with PRO in that you all focus a lot on the prevention, all those kinds of public education issues, whereas PRO is focused especially on actually providing care for people who recognize they need care and don't have access to it. So one, we have a mechanism for doing the service. You all certainly talk about those issues and help provide that. But there's a big job we have in this community, and it's not just low-income people or even uninsured people. But I'm a bit concerned that we're now increasingly having, for example, vaccines, preventive vaccines. It's possible now to have a vaccination that will keep you from getting shingles, which is a really awful disease that older people, anybody who's ever had chicken pox is liable to have that. People 60 and above should have it. It's probably most effective between ages 60 and 70. I don't think our elders, whether they're low income or middle income, they're not being told about this.
And that's one of the things I really want to piggyback on that point. We find that there are programs that are designed for specific target population groups, and yet those population groups don't know that they exist or how to actually get involved in them. And that's one of the main emphasis that CASH is trying to do. We're not trying to duplicate any service that is already being provided, but we want people to know that you can get this service. So we send out a monthly newsletter called Connections, and the subtitle of the newsletters is News the Community Can Use. And what we try to do is tell them about these very kinds of available services and how they can go and access them. And so if anybody is interested in being added to our mailing list, they should go to our website, which is www.cachenc.org, and just sign up for our newsletter. Exactly.
And can I jump in here to say that we're taping this in October, and the flu season is about to start. So anybody who is at risk, and that means anyone my age, I'm sorry to say, should go and get our flu vaccines. And while you're at it, a flu vaccine is every year, but there's also vaccination against some kinds of pneumonia. And older people should have this inexpensive vaccine, which actually is very important in terms of preserving life, because pneumonia is often a very serious source of mortality, that is of death, for older folks. So if you can get both the flu shot and the pneumonia vaccine, that would be good.
And I think I'm right in saying that people can access these services through community health services. We actually have community health services come to the United Way for those people who want to get their flu shots. We try to make it as simple as possible.